I'm Professor Mitch Dowsett. I'm the head of biochemistry at the Royal Marsden Hospital and the Institute of Cancer Research in London. I think there are actually two ways in which we can improve this. One is technical, and the other is assessing these in large clinical trials in an appropriate fashion. Technical really means that we are testing and validating our approaches to the testing much more fully before we start to implement these and indeed report on them. Otherwise we're likely to mislead the oncologist and the academic community. The second thing is really to actually understand that to get confidence in our data, we really need to power our studies appropriately. And really in the modern day this means linking into adjuvant trials with thousands of patients in. At the moment I think it's difficult to say that they're actually improving outcome. What they're doing really is leading us to use our treatments in a more targeted fashion such that we can identify the women that are most likely to benefit and to direct therapy most appropriately to them. Essentially tailoring treatment for individual patients is possible with some of these new biomarker tests. Again, I think there are probably two issues here. One is, as new tests have been discussed on the podium, really to think about whether the data being presented to them is strong, whether there are indeed sufficient patients to be involved. Are the tests have been validated before they've actually been assessed in these clinical trials? But more particularly for those tests which are already established, to ensure that their laboratory back at their local hospital is in fact participating in quality control schemes that establish that they're doing these tests to good quality, and we can rely on those indices for selecting patient treatment.